Yeah, so I'm going to talk about patient and family involvement in resilient healthcare. Hopefully provide an introduction to this topic and also give you a brief overview of the sort of things that patients and families do to promote or co-create resilient healthcare. So just want to start off by saying that I'm going to be talking about not the resilience of individual patients or family members, but more what these individuals, so patients and families, what they contribute to the resilience of the system, the healthcare system. And I'm going to provide you with some examples from different studies that have been done. So the background for this talk today is that today we've already heard a little bit about adaptive capacity, complex systems, and given some examples of the capacities that are necessary for resilient systems. And not least, we've also heard about the importance of studying everyday work and work is done to understand how resilience comes about, or what adaptations are happening that create resilient systems. And usually, the research that has been done, most of the research that has been done so far involves looking at what healthcare staff are doing and what work they are doing and what adaptations they are making and contributing to. But in the recent years, so maybe in the last sort of 5+ years, we've seen that patients and families also contribute to adaptive capacity and are enacting adaptations that contribute to the resilience of the system. But there's been a few reviews from Berg and colleagues and Ellis and colleagues and Iflayel and colleagues that have all noted that research on what patients and families contribute is lacking. So there's still quite a lot of work to be done in this area. And like I said, I'll be sharing some of what's been done so far, but I just want to really reiterate this point of why it's important. And I want to paraphrase Jane O'Hara and Carolyn Canfield and Karina Oss's work, where they basically argue that we have to integrate patient and family perspectives and contributions to resilient healthcare as a logical imperative. Because if we don't do that, we won't actually understand the full range of work is done. We won't actually have a complete picture of work is done. So we won't actually have all the puzzle pieces necessary to understand the system and the resilience of the system. So what's empirical work has been done so far? I've tried to collate an overview of the different sort of topics that people have looked at. These are empirical studies. All of these are empirical studies, apart from one, which is a review, a scoping review. I'll get back to giving that as an example in a bit. So what you can see is that some work has been done on medication management. Some work has been done on transitional care. There's been some work on cancer care. There's been some work on investigation of adverse events and family involvement in those types of investigations. There's been a bit of work on patient involvement in mental health and patient care. And most recently, there's been also some work coming out now about what patients and the public have contributed when it comes to COVID-19. And I'll give that as an example as well. But first off, I want to start with some of these projects that have been done on medicines management. As you can see, there's 3 studies that have been published. I don't know how easy it is to read the titles of those, but they're all studies from the UK. A lot of this work is coming out of the UK. Family and patient involvement work is coming out of the UK. And this is some work from Beth Filan and colleagues, where what they found is that both patients and families contribute first and foremost by anticipating and responding to system variabilities. These system variabilities or gaps in the system could be lack of information given to patients about medication management at either admission or discharge. They see that their patients and families are sort of propping up the system when it comes to discrepancies in medication prescription and supplies. So, for example, they pick up on errors that are in prescriptions, and they will relay correct information to the pharmacy before filling their prescriptions, and that sort of thing. And they also keep on top of medication errors and safety incidents to do with medications. Another thing that they do to promote resilience is to actually establish strategies to enhance either medication adherence or just management of medicines. It can be, for example, to make sure that the correct information is given between care providers. So, for example, between the hospital at discharge and to the GP in the community. If that information is lacking from the physicians at the hospital, then the patients and the families can sort of bridge the gap there by providing the correct information. And these studies also found that a lot of what patients and families do is to seek information online to fill the gaps and the information gaps that might be there. They also do a lot of work to do with stock control, as in making sure that medications are stocked up at home. They may change their routines or set alarms or use visual cues to promote adherence to medication. Those are just some examples from these studies on medication management. Also wanted to include some examples from transitional care field. And these are also some very recent studies by Jane O'Hara and Ruth Baxter, who will probably both be here tomorrow. And so if anyone's wondering about anything, you can also ask them directly. So they've been looking at transitions from mostly from hospital into the community or to the home. Looking at what patients do, but also families. And this is actually an example of a study where they use the FRAM to model the functions of these stakeholders, and explicitly using the FRAM to integrate the multiple perspectives from different types of stakeholders. So what these studies have found is that patients and families engage in several types of activities or functions and types of adjustments during the transitional care. These are to do with activities of daily living, for example, to do with mobilization or preparing meals, making sure that patients are being fed, getting meals. Again, this sort of study also found the importance of what patients and families do in terms of medication management. Also, some findings here on what they do to manage recovery. For example, monitoring patients' condition, making sure that patients attend appointments, and that sort of thing. And also some findings here on the important functions that families, in particular family carers, have when it comes to knowing when it's necessary to escalate care for patients. And what O'Hara and colleagues note here is that all of these functions or all of these activities are things that, when the patient is an inpatient in the hospital, would be tasks that the clinicians are doing or providing for the families. But once they for the patients. But once they leave the hospital, of course, someone else has to provide them or do provide them instead. Moving on to an example from cancer care, we're also in this. Inger Bergerød is also here at the conference, so if anyone has any questions about her study, you can ask her as well. And this is, so Inger's study is an empirical study, and the other one from Tilbrook and colleagues is the scoping review that I mentioned before. It's Inger's study focuses on the family perspective, or the next of kin, whereas the scoping review looks at what both patients and families are doing in cancer care. Both of these articles are in Journal of Patient Safety. So these are the types of activities or adaptations that patients and carers engage in. And again, you might be able to see that some of the activities mirror what I've already noted in the other studies. So it's about filling the gaps in the system to do with care tasks such as feeding or medication. It's about anticipating changes in the patient's condition, for example, to do with the effects of treatment or other forms of deterioration. It's about monitoring and responding to patients' condition and needs. This could be in terms of pain management or activity levels needed. Interestingly, also, the studies found that patients and families are actively influencing healthcare professionals' decision-making, both with regards to admissions, for example, or discharge decisions. And importantly also, family members in particular are very important when it comes to communication efforts between healthcare providers and patients and families. They provide a lot of care coordination work, and they often help the patient navigate the system. And finally, the example that I wanted to show is this recent study to do with COVID-19. So patient and public co-creation of healthcare safety and resilience in terms of the COVID-19 pandemic. So the aim of the study was to understand what people were doing in the first wave of the pandemic. And this is, the context of this is the NHS healthcare system in the UK. And what they found is that from the public side, so people who are not necessarily in need of healthcare services, so you're not defined as patients to start off with, they supported system resilience by adapting their behavior. So they actually avoided seeking help, for example, healthcare services in the short term, and thereby helping the system not become overwhelmed during the first wave of the pandemic. And whereas patients or people who have existing conditions or could be defined as patients, they reported that they still experienced gaps in their care during the pandemic, and they engaged in increasing scaffolding activity, so scaffolding being the work that they do to sort of uphold the system. And these were, of course, different for different types of patients, so personal circumstances would affect the amount of work they did. And I think also importantly here, a finding is that they also noted the burden of long-term monitoring activity and how this was increased during this first wave of the pandemic. So I wanted to end on just a summary of what these stakeholders are actually doing to contribute to resilient healthcare. So it's sort of to collate the findings from these studies and also from some other work that we are currently doing at the Share Center in Norway. We see that they're providing safety critical information, for example, regarding medical history, medication, and treatments that the patients are undergoing. There's a very important role of transferring knowledge or information across stakeholders. So basically keeping oversight or keeping a hold of the patient's sort of oversight of the patient's journey through the system. They're monitoring and observing and responding to the patient's conditions and the treatment that the patients are receiving. And also filling these gaps in the system when it comes to practical and clinical care tasks, such as, again, such as feeding and medication, for example. And also, again, this interesting finding about actively influencing care decisions. Healthcare process decisions. So, again, to do with referrals or admission, discharge, or treatment decisions. And just to end, I've got some thoughts on what might be interesting to look at further and further research to get more of these puzzle pieces that we still need. First of all, I think we just need more research in general in this area about who is involved and what they are doing. So how are they involved and with whom? We're seeing some interesting, we've got some interesting findings in our work in the Share Centre to do with the differences between patients who have families involved and the patients who do not have families involved, and the different vulnerabilities that come up, and how they're able to influence, for example, care decisions and that sort of thing. I think we also need more research on when they become involved in resilience and in what context. There's also interesting to look at this aspect of stakeholder relationships. So Birten mentioned earlier about the relationships between managers and healthcare staff. It's a very important relationship, and also the relationships between staff members. But I think also the relationships between patients and families, of course, but also between these stakeholders and other stakeholders, such as staff members, healthcare professionals. I'd also would like to see a wider range of studies from empirical settings, other types of healthcare settings than what's been happening so far. And again, the impact of context. We've already discussed this a little bit today, but I think more studies from different cultural contexts, for example, or studies that look at the influence of different local contexts across, for example, different hospitals or community settings within the same country could also be interesting. And not least, I think it's also important to ask the question about resilience for who, because we've touched on this. I think we've already touched on this a little bit today, but I think we can go into it a bit further, because if you think about it, the system can seem resilient and that things are happening as they should, but we don't necessarily talk about maybe at the cost of what or for who. So what is the cost to the family member who's doing all this work to uphold this safety and quality of care for the patient? What is the cost for these healthcare professionals who are working behind the scenes almost to sort of uphold the system? Is it the cost can be, we've seen this with the COVID pandemic in terms of burnout and people leaving the healthcare professions. So yeah, I think those are some of the thoughts that I would like to leave on today. Thanks very much.